I'm John Mills with CCHF, so I'd like to welcome you all to this last breakout session of the day, but don't go anywhere because at 7 o'clock we have our first major plenary session tonight, so you've got that to look forward to. But in this session, we're going to be talking about cool things that are happening in our Christian clinic world. I spend a fair amount of time talking with clinic leaders from across the country. And I'm almost always, thrilled and impressed by what I'm hearing about what clinics are doing. But occasionally, there's a really innovative or cool idea that I hear about. And I try to explore more about what those things are. And so, like, for example, there's a clinic in Fort Worth, Texas that does cataract removals. It's a free medical clinic called Cornerstone, and in our world, you do what you can pull together as far as resources. And so Allergan, I think, is the name of the company that's headquartered there, and they came in and built an entire suite for this clinic. And then they use volunteer ophthalmologists who do the cataract removals. That's just not normal in a free medical clinic. We've got organic farming happening in clinics across the country. I mean, not just a garden outside your clinic, but a farm. They've got farmers on staff, and the physicians write prescriptions for garden vegetables for the patients to collect. And so, there are cool things happening. Early pregnancy intervention is happening in some clinics where the clinic staff is loving on folks that are newly pregnant and maybe not sure what their options are. And so today I've got three folks on our panel who are going to spend about 15 minutes or so telling about what they are doing in their communities. And at the end, I'd love to be able to just see who else in the audience has something cool that they're doing, as well as, get any questions answered. And so we've got three panelists, so we're going to, run through three different separate presentations. So give us a little grace as far as that transition time. And then hopefully we can go right through here. So let me introduce our three panelists first. Dr. Wiley Smith, raise your hand, Dr. Smith, is a family physician living in Dalton, Georgia. He graduated from the University of Health Services and served as an Army medical officer for 20 years. I'm sorry? Yeah, go Army, okay. Then he moved his family to Belize and worked in a medical clinic there in a village for 9 years, serving with the Mission to the World Presbyterian Church in America. And then they moved to Dalton, Georgia in 2009, and because, physicians don't ever stop working, he founded Grace Medical Outreach Ministries, which is devoted to providing house call medical care for homebound patients and their caregivers. See, here's the innovative and creative idea. House call ministry. Wiley and his wife Karen have 4 children and 8 grandchildren. Rusty Price, on the end, is the CEO and founder of Camino. Price is a church planter extraordinaire. I think he's been involved with maybe 300 or so church plants. And the interesting thing is that it's in the Latino community. And so Rusty is also a tremendous fundraiser, and he's built this great organization. You'll see a little short video about it. They're providing health care and food services and outreach and training in Charlotte, North Carolina. And so Heidi Christensen is a public affairs specialist with HHS, Center for Faith-Based and Neighborhood Partnerships. Heidi is a public affairs specialist at the center And our efforts focused on strengthening the capacity of faith and community organizations to respond to critical public health issues. And so Heidi will be telling us about efforts to engage the faith community and partnering with health clinics to make that happen. So Wiley, if you'll get us kicked off here.
Okay, well, thank you, John. I think maybe we had a little false advertising. You came here to hear about something really innovative and new and high tech and everything, and what are you going to hear about? House calls, okay? Doctors used to do house calls with horse and buggies and a little bag and everything, and so what place does that have in modern medicine and such forth? But I want to be a salesman for house calls and also to kind of give you an idea of how it can fit in with our faith-based efforts, Christian efforts, and such forth. Now, tell you where we are. It's a place called Dalton, Georgia. That's known as the carpet capital of the world. Okay, if you need something on your floor, we got it for you. Okay, and as it turns out, we don't operate a fixed clinic as such, so I feel a little bit like an odd duck here with all these wonderful clinic and hospital-based folks running big residency programs and everything, and we're just this little outfit in a small town in Georgia. Let's go with the second slide there. Now, where this all started actually was kind of overseas. Like you heard, I was an Army doctor for 20 years or so, and I was declared surplus and retired, and we moved to Belize, and I worked in a place called the Presbyterian Medical Clinic. It was this little clinic out in the sugarcane fields in the north part of Belize, and it was more or less like a regular clinic. People would come in, and I'd see them for 15 or 20 minutes, and then we'd go to the pharmacy, or maybe we'd do a little bit of lab testing on them and everything, and then out the door they went. But from time to time, I was asked to go do a house call. It was usually for some elderly person who couldn't get to the clinic. And right down the road from us, there was this thatched roof hut, and this elderly lady who was deaf and blind, okay, and the language she spoke was Maya language. I spoke a little Spanish, but I couldn't talk to her in Maya, so how was I going to communicate with her? Well, she would feel the head of my stethoscope, and she'd get this big smile on her face, and she'd know the doctor was there to see her. And I got to really enjoy doing these house calls because not only did I have a real bond with the patients, but I got to know the families, and I know their situation, and I got a lot more information about them and built up quite a relationship with them. So when our work in Belize kind of wrapped up, it turns out Belize, little bitty country, figured out how to do some sort of national health care system, and our clinic got some funding, and they could hire a national doctor, so the missionary doctor didn't have to be there anymore. So our work in Belize was pretty much finished. And let's see, let's do next slide there. We looked for a place where I could continue to do house calls. In particular town of Dalton, Georgia, I had some friends at a church called Grace Presbyterian, and did a little survey with them, talked to the folks in the church and the folks in the medical community, and we found that there was no other doctors or anybody in particular in the area that was doing house calls, and in particular the home health nursing agency said, we got this big problem. People are coming out of the hospital, they don't have a primary care doctor, and we can't do our job with them because they don't have a doctor to sign the orders or supervise or do anything like that. And just a lot of difficulty with that. So we found that there was a significant population of unreached folks who were housebound that needed some care. And there were palliative care and hospice could help folks who were kind of nearing the end of life, but there was a lot of people out there that were not, could not be identified as being particularly eligible for hospice care. And it was quite burdensome for people who were homebound to get to primary care. They had to book an ambulance ride, which their insurance may or may not pay for. Usually it was something like $500 a ride or something like that, or other non-emergency kind of transportation. There's a county transit van that went around the county that will take people in wheelchairs, but that was really exhausting for patients and it's not really reliable and such forth. So there was a need, and the fact that there was not very much any kind of house call service in the area there, well, in the country in general. I mean, there are some places where you will hear about home-based primary care and concierge medicine for rich folks who can pay a monthly fee or something like that. But for the most part, Medicare and Medicaid doesn't pay adequately for regular doctors to go out and do house calls, so that practice has kind of faded into the background. Now, next slide. There is another thing that we consider in the spiritual realm. You will recall in the book of Matthew, the Gospel of Matthew, where Jesus is talking to his disciples about what's going to happen at the end of time, where the world is basically divided into two groups, the sheep and the goats, okay? And Jesus talked about sort of the characteristics of the sheep and what the sheep were doing. They were clothing the naked, visiting people in prison, and he said that they were visiting the sick, okay? And he equated it to visiting him, okay? So I think I'd rather be doing sheep stuff because the goats really, they lost out, okay? I'd rather be on the sheep side, okay? All right. Next slide here. So what other arguments can we make for doing house calls? It's kind of the research and such forth on it. There have been a number of different studies done. Some have been inconclusive, but there have been a number of them that demonstrate that physical and spiritual care for homebound and indigent patients can prevent unnecessary hospitalizations, people coming out of the hospital, early readmissions. You know, Medicare kind of doesn't like it when hospitals discharge somebody and then come right back in. The Medicare will ding the hospital. So those are things that we might seek to prevent or to promote by doing house calls for folks. So let's see here. So next slide. We had to have a mission statement for what we were doing in our organization. What happened was that my friends at the church, we had some lawyers and folks like that, and they helped us set up a 501c3 charitable organization, and we so sort of got the ball rolling with that, and we got a board of directors and that sort of thing, but we needed a mission statement. And our mission statement says we're providing medical, physical, and spiritual care for homebound and indigent patients and their caregivers. Now, you'll notice we included caregivers in it, okay? What we found as we go around and talk to families and talk to patients and such forth, that we really need to minister to the caregivers almost as much as we do the patients, because they have a big job. They're often overwhelmed and depressed and under-resourced to take care of their sick loved one, or their homebound individual and their family. And so we have to kind of consider them too. And medical, handing out pills, do it all the time, but there's other things we need to consider: the physical, the living situation, you know, is the floor falling in, is the roof leaking, that sort of thing. And then there's the spiritual care, okay? We need to look to that. And so the paradigm of house calls, where we have more than just 15 minutes in the clinic, is ideal, where we can address all three of those things, okay? You hear about what they call the SDOH, the the phys- determinants of health. Okay. The social determinants of health. That's it. Okay. So this is the paradigm that we can best address those sort of things, and we get a lot more information. Like I have what we call the refrigerator biopsy. Okay. You want to know why your diabetic patient, their A1C is 13 and their fasting blood sugar is 327. Well, you open up the refrigerator and it's full of Dr. Pepper and Coca-Colas, then you know that's the problem, okay? Their diet is not what it should be. So we can just do a lot of good things with house calls. All right, next slide. These are some of the kind of things that we have employed that have helped us out, using free electronic medical records, okay, so that we can pull it up in the field, we can pull it up at home. Our staff and volunteers can work from home, and that really came in handy during the pandemic, okay? Second is we decided not to charge our patients and not to charge insurance either, okay? There's a few reasons for that. One is that our patients are mostly poor, and they probably already have massive medical bills, okay? And we don't want to add to that. Second is we'd rather not spend our time coding and fighting insurance companies and trying to justify what we're doing and such forth, and complying with regulations that although they are good in a clinic setting, they're not really applicable or practical in house calls, okay? And there's another factor that people kind of get scared of is malpractice, okay? And Georgia, and I don't know, maybe other states too, has this what we call a Good Samaritan law that says if you're providing free medical care, then you are pretty much exempt from malpractice unless you're being just particularly malicious, okay, which we're trying not to be, okay? So those are the factors that kind of lead us to not charging, okay? So you say, hey, well, how are you going to fund your efforts and everything? What we found is that the mission that we have enjoys a lot of sympathy. The word gets out, and with just ordinary fundraising measures and such forth, we're able to keep the operation going. Now, it does help to have volunteers, okay? Actually, I'm a volunteer too, being a retired Army type and having reached Social Security age. It's not necessary for me to be paid for my efforts. We're also kind of pursuing grants and such forth. Georgia has what's called the Georgia Baptist Healthcare Foundation, and we're agitating with them for a sizable grant. And although we've been operating for 14 years now, I think we're still in our infancy, but we're reached to the point, I think, where we are going to be able to expand in the next year or so, hire a nurse practitioner. We've talked about social workers. A lot of what we do comes in the realm of social work, so if we had more than our amateur social work going on, I think that would help us. So I think it is possible and practical to do something like this on a charitable basis that really helps out the patients. And then we're also kind of looking at things like cooperating with medical residency programs. Our hospital in Dalton actually has a family practice and an internal medicine residency program, and we're agitating with them to have their students come out and do house calls with us, and I think that can help the students and help as well. And social work as well. We have some social work schools in our neighborhood where the students there need practical hours and such forth, so we got plenty of social work for them to do. All right, next slide here. Okay, so there's just a little bit of statistics. In our 14 years of operation, we've seen about a total of 700 individual patients. Our census at the moment is roughly 60 patients that we visit. The visitation kind of depends on what they need. Some patients we're seeing on a monthly basis. Some people we're seeing every 3 months or so. Just kind of need what we need. I do my house calls on 2 or 3 days a week. Okay, we have 2 hired part-time nurses, one is on the telephone all the time, kind of connecting with our patients and getting appointments set up and such forth. And then most recently, we've hired a very hotshot nurse to be our executive director, so she's helping us grow and doing fundraisers and recruiting volunteers and just doing all sorts of things. I thought I'd give you just some example patients. Next one. This is a fellow named Benny. Okay, he's 84 years old right now. He's lived alone for quite a few years after his wife died. We met him about 4 years ago. The home health nursing agencies called us up and said, we have this patient. He's living in the extended stay Scudsy Motel, and he just had a 4-vessel bypass operation, and he's had a stroke. He has no money. Okay, all right, so he was literally existing off of rice and beans because his Social Security check barely covered what it cost to stay in the motel. Helped him with medication. We helped him get to the cardiologist for his checkups. We helped him with food, and rather miraculously, we were able to find him an apartment in a subsidized senior apartment building. These particular apartments in our town have like a year-long waiting list, and it was miraculous that we were able to get him in within a couple months. So that was really nice. Talking to him some more, we found out he was a veteran. He was in Vietnam with the Navy. And so we got him set up with some VA pension money and such forth. Spiritually, he's a very strong believer. He loves to read his Bible. But he developed glaucoma and his vision was going downstream, so we had to get him to the ophthalmologist and get him with he had some operations done and such forth, and his vision is stabilized. These days, he's getting a bit on the dementia side, and he's got some renal insufficiency cropping up, so we still have some challenges to face with him. Okay, next slide. This is a lady named Amy. She's about 25 years old, and she was born with sort of paraplegic cerebral palsy, and she's been in a wheelchair for a long time. The reason why she couldn't get to the doctor was because her house had no wheelchair ramp, okay? So we kind of got her stabilized with medications and various different things that she needed, and then we arranged to get a wheelchair ramp built on her house, okay? We partner with other agencies in the area. There's a outfit called Rebuilding Hope that does housing rehab and wheelchair ramps, okay? So she's not my patient anymore. She's able to get to a regular doctor because we got her ramp built, okay? Next one. And this is Beulah. Beulah is a 60-something-year-old lady who suffered a bunch of strokes and left her wheelchair bound. And her caretaker is her husband, and they lived in a very rundown mobile home, which are very common in northwest Georgia, okay? And particularly this mobile home had no kind of handicapped bathroom, okay? So next slide. So once again, we called on our church resources. There were a couple of teams that came for the summer to Dalton, Georgia, and we had them build on a handicapped bathroom onto the lady's house. So that greatly enhanced her husband's ability to help her out. So once again, this is kind of illustrating going after those social determinants of health. Okay, next slide. Okay. Spiritual care. Like I said, we want to integrate the spiritual along with everything else, and this is something that we can do much more effectively in the house call model, in that we have 45 minutes or an hour with these visits, okay? Our main weapon is prayer, praying with our patients. Our patients really get used to this, and if I forget to pray with them, they say, "Hey, you forgot to pray with me, come back." Okay? All right? Handed out things, large print Bibles, audio Bibles, And I'm particularly fond of devotionals written by Johnny Erickson Tata. I don't know if you're familiar with her. She's a lady who has been in a wheelchair for many years and has written a whole lot of very good devotionals that are geared for people with disabilities. What we find is that a lot of our patients, being Northwest Georgia, church on every corner, have heard the gospel at some point in their lives, but it has not kind of taken root into their lives. But in the situation where they're disabled and homebound, they have time to think about these things, think about their lives, and it kind of leads to the ability for us to present what we call the medical gospel, okay, what I call medical gospel. And it goes like this. Okay, I'm a doctor, and I'm going to give you some pills, okay? And there's other doctors that cut on you and stick things inside of you, okay? And what we're trying to do is help you feel better, perhaps live a little bit longer, okay? But ultimately, our medicine is weak, okay? We can't keep you alive forever. However, we'd like to refer you to a much better doctor who can keep you alive forever, and we call him Dr. Jesus, or the Great Physician. So we try to kind of steer them in that direction, and we have had a good bit of success with that, with people who have come to Christ and I feel much better about their situation in that respect. Okay.
Need to cut you off here.
Okay, anyway.
You're running into our other panelists.
All right, pray for us, okay? Pray, okay? All right.
Thank you, sir. So, who wants to go next?
All right. Thank you, John. And thank you, Dr. Smith. Hi, everyone. My name is Heidi Christensen. I'm with the Center for Faith-Based Neighborhood Partnerships. We're located in Washington, D.C. It's a federal office in the Department of Health and Human Services. And I had been in touch with John, who, because I've been thinking about coming to this conference. I'd heard all about the great things that the Christian Health Fellowship, Community Health Fellowship, anyway, you got we're doing. So I called, and so they said, well, you need to talk to John about what you're doing. And then I just told him what we were doing at the federal government, and our office said, well, you need to come onto this panel and share kind of what you're discovering around the country from other entities. So that's what I'd like to share with you today. And also, but truly, I have a bunch of cards here, and I'd love to hear from all of you. So I don't have a bunch of slides. I'm just going to chat with you. So as John had mentioned, our primary function at the Center for Faith-Based Neighborhood Partnerships is to strengthen the work of faith and community organizations, congregations, and providers to the critical health issues facing our country. I've been there now through 4 administrations. And so I've walked through, everything from trying to end the trend of childhood obesity to COVID prevention, the opioid crisis when it was called on as a public health emergency in 2017. And then we do a lot now with maternal health and mental health and substance use disorder prevention or recovery. So, but one of the ongoing efforts, and what I focus specifically on, is building reciprocal bridges between clinical and faith groups, and trying to really identify and strengthen and share the extraordinary assets that they each bring to the continuum of primary and mental health care. And so I'm going to focus a lot on mental health care for this conversation today, and the work we are doing to actually increase direct access to mental health care counseling services in or affiliated with houses of worship. This is the first group I probably will ever speak to who will say, we know exactly the value that faith communities bring to mental health. And so there's so many reasons that they're so poised to support the mental health and well-being of our communities. Like, of course, we think of them as a place, especially, in a time when community is so important, when we have an epidemic of loneliness and has now been identified as a chronic condition. They also offer that narrative of well-being and belonging with hope, celebration, meaning, purpose, life cycle rituals, service to others. as prescriptions not only for a healthier life, but also as protective factors toward future harms. So often these intangible benefits come alongside the very practical missional capacity of faith communities to provide, as we were talking about, home and health and hospital visits, food care, transportation, job readiness, mentorship, ESL, financial literacy, hosting recovery support groups, and the many other ways that they practically and pastorally walk with an individual recovering from a mental health condition or building a life free from addiction. We also recognize the power of the pulpit, where clerical leadership can reduce stigma and shame that's often associated with mental health care, a mental health condition, by speaking openly and supporting services and creating access to treatment directly in their community or to to a partner. With a diminished healthcare workforce, we know that is a real issue in this country right now. There are existing roles baked right into congregational life that may include the pastors, the deacons, the chaplains, the faith community nurses, even community members, with skills that can be elevated or task shifted to better serve community members experiencing mental health illness, or to refer well to, or act as bridges to professional services. But still, we know too often that the faith community and the clinical care providers are siloed from each other, or what I hear very often is that faith communities are engaged more in an outreach capacity. So, like to host a health fair or to promote healthcare services. And it's very good, it's all really important, but it doesn't really tap what we think is the potential that partnerships with faith communities can bring in support of behavior change, care management, and even in supporting the adherence to medication protocols. So our office has been focused on exploring and defining the best practices that strengthen, formalize, and operationalize, and that's the key, bi-directional partnerships between faith communities and social and clinical health care providers. And so we had this benchmark moment last September when we hosted an invitational workshop, and we brought about 13 models of care delivery models providing direct access, and that was the key, mental health care and counseling in a congregational setting. And the goal was to, of course, identify best practices and to learn what are the key pieces that are actually operationalizing these models so that we can share and others can learn from. And we discovered, so there's a lot of learning there, and we discovered collectively 13, these are just the 13 initial models, and since then we know of so many more. We're providing over 46,000 clinical hours of mental health care counseling annually. And they are provided, including psychiatric care, at mostly no cost or at a sliding scale. Now, for instance, like a church in Louisiana, they have 2 full-time counselors, and they provide about 1,300 hours a year. And another very large Texas steeple contracts 12 counselors, and they're providing about 12,000 clinical hours through telehealth now. And I have lots of examples that I can share with you. But we also really discovered that the delivery model had the delivery models each were like unique because there was cultural and nuances, and of course the capacity of each community is so different. But we found there were basically 3 primary organizational structures. The first one was an embedded on-site professional counseling and support center, where the faith community founded the clinical center. They fully support the ongoing operations. It is co-located in or near the house of worship. They employ the staff affiliated with the program, including paying the clinicians or their fees for contracted services. They cover the operations and the cost of the facilities and maintenance. Now, there's a lot of benefits. For the highlighted benefits of that is you're going to have the programmatic flexibility. The faith community can better direct their scope of services. They can determine who they want to serve, when they want to serve, and where they want to serve. The possibility of a deeper integration of faith teachings into the counseling services, if requested, and I think that's key, has greater latitude. The ability to coordinate that wraparound services, what the church is probably already doing in their the health-related social determinants that are provided by the community, can have that greater integration. So that's all there. And you know what, I'm not going to get into those examples right now because I want to spend more on the examples later on. The second model of care was pretty much in the same vein. They're formed as, they're 501c3s, but they're still pretty much embedded. And so it's a variation on that first, but it's different in the, some key ways, which are they can be more easily supported by grants external to the congregation, right? They may be able to participate in payer reimbursements or pay directly or bill directly for services. And they have a board of directors. That could be both helpful to the community connections that involves, but also it adds another layer of governance. The third care delivery model that might be most, I thought, coming to this, but I don't know, most relevant to our discussion today is the partnership model. But actually, we believe partnerships are the key to everything. I mean, really, and I have a lot to say on that. But in an ideal form, the partnership model is when the congregation formalizes an agreement with a social service agency or provider who dedicates culturally appropriate licensed professionals to serve their house of worship and provide support, education, and triage to outpatient mental health and related services. And of course, the benefits of this model is going to be that the faith community has access to mental health, medical experts, and a full complement of social services. It's a much reduced burden on the faith community of having to actually develop an in-house mental health or social services infrastructure. And in most cases, the partnering service agency is able to bill for reimbursement. I mean, that sustainable piece is really actually is an important factor. And I'd like to here's a few examples. So, Catholic Charities in Trenton, New Jersey, they're a part of a network of certified community behavioral health clinics. They were part of a state demonstration program, and they deploy culturally appropriate teams who go in, they set up a virtual exam room in congregations, and then they triage from there and provide mental health care services and health care via telehealth. The on-site care teams could be made up of a community health worker, a med tech, LPNs, of course, medical doctors and personnel, but also medical nursing and social work students. Their local FQHC is integrated into their hub and spoke model to address primary health care needs. And the role of the faith community is that they host the care team. And they act as liaisons. They identify high-need patients. They are promoting the services, hosting educational events. They oftentimes will provide the translation services. They are then, of course, addressing these social determinants of health. They're working with the wraparound services. So it's really a very bi-directional partnership. Her Story, Inc. is actually a model right up the street here in, well, I don't know if it's up the street or not. It's Xenia, Ohio, but it's not too far. Yeah. And so it is. So the rock star, Dr. Beth Delaney, and I work a lot with the Delaneys through the years, and that is a community-based care provider. They manage a church partnership program that provides outreach, education, and an intensive outpatient program in 6 different congregational settings. They serve about 600 annually through these church relationships. So they provide the intensive outpatient, the IOP, on 2 church campuses and partner with several other houses of worship to provide counseling services. And then they have a working relationship with an FQHC where they refer clients for the psychiatric care and also for primary health care needs. Her Story is really fantastic because as an accredited provider, they are able to accept Medicaid, private insurance, et cetera, and obtain grants. And then they support the hosting faith community with a share of the revenue so that they're actually compensating them for the use of the space and their partnership. New Destiny Christian Fellowship in Detroit supports a clinic that's a very big church up there in Detroit, but what they have is a family nurse practitioner who's on site, and she's a member of the church, and she acts as someone who basically assesses, does some on-site counseling because she has that capacity, but she mostly triages referrals and a warm handoff to a direct partnership they have with the Detroit Wayne Integrated Health Network, which is an affiliated care network. So they're basically, she's acting as this kind of referring hub. And in this case, the church is working in concert with one full-time provider that has a vast network, and because the nurse practitioner is able to provide counseling and support, she also can take some of the burden off the workforce of the provider because she's able to actually stem and take some of the care off the hands of the provider. Detroit Rescue Mission Ministry is part of the Citygate Network. Do you all remember them, formerly the Gospel Rescue Mission Ministries? And they're a certified community behavioral health clinic now as an expansion grantee, and they broaden their partnerships with churches by co-hosting mobile health clinics. And so this is not just a drop into your parking lot. I mean, it is a real full co-hosting where the church is identifying, referring partners. They have educational campaigns. They work with the youth ministries to do some of the social needs around that. Mobile health, I'm sure this seems to be something that's got some real traction here in this community of you all. But this had a 40% growth in health center mobile units since 2019. And there's lots to be said there, but I know that we're looking for additional federal money to come down, to be soon available through the 2024 New Access Points Grant, which of course as soon as the budget gets released, that'll be forecasted. Right now it's forecasted for, everybody's looking at that one. So, and I know, yeah. So, I would love to share these examples and more, but I feel of all the providers in the universe, if you and I can't figure out how to really strengthen these models, I don't know who can. I mean, I would love to talk to you more about what we're seeing, what those practices are looking like, what's emerging, how do we equip and operationalize this movement. We are hosting a part 2 of that gathering I told you about last year, this year, where we're really going to focus on this partnership model. So if that's something you're interested in, please let me know. It'll be in DC. And also, if I have a moment, am I running over? Am I over?
You're pretty close to being done.
Okay, so I'm going to say, I'm sorry, I'm just going to say one real quick thing. We also have, there's a pilot program in, well, you know what, I'm going to say that later. I'm not going to take away from Rusty, so thank you, but.
Thank you, Heidi.
Hey, my name's Rusty, and they have me listed wrong on here. The letters after my name shouldn't be CEO, it's ADHD. So this is going to be fun. So my name's Rusty. My wife, Anna, is back here, wife of 34 years, 4 kids, 6 grandkids. We just had one like a week ago. And grandkids are God's gift to you for not having killed your children. Also here with Sharice Johnson, executive director of our center. She's Puerto Rican from the Bronx, which we found out is the most dangerous land animal in the world. And no, I'm teasing. But we have served the Latino community most of our lives, and ignorance with passion has always been my mantra. So we've never been very strategic, but we've tried to follow God by faith. And so right now we have a center in North Carolina. And talking about these models, Heidi, we have a church, and then we have a nonprofit. My wife and I wanted to be missionaries to Cuba, so we started a nonprofit. Cuba wouldn't work with a faith-based organization, so we don't have any type of faith in our bylaws, and there's no requirement for faith. So it's a partnership between the church and then this faith-filled organization that co-share a name. And then in the community, it looks as if the church is doing all the work, but it's helped us tremendously on the backside with funding, as well as hiring, because we have no faith requirement for our staff. We have a research institute that has been revolutionary for us. We find that as a pastor, stories change hearts, but if we want to change systems and processes, it has to be data. And so we've just conducted the first strength and needs assessment of the Latino immigrant community in the state of North Carolina. And one of the things that came out of that was the number one place that Latino immigrants go when they have a need is to their faith leader. So now we're not just talking about a narrative, but we're actually showing empirical data that the best way to reach this very hard to reach group is through their faith communities. And it's because trust is the number one economy in that community. So as we've been doing this, another thing too, again, my father was a pastor, my grandfather pastor, 5 uncles pastors, 2 brothers pastors, 2 brother-in-laws pastors, one that I don't like very much. And so I was born in the mafia, I was born in the ministry, and so many times, church has become an industry, right? And so the big end game is sustainability, not transformation. And so one thing we find too, especially in a lot of the Latino churches, that these guys are struggling for finances. And very few of the ones we work with work with the older line denominations. So many of them are just small independent churches, bivocational pastors. And we always say a lot of Sundays they come and they're not preaching for transformation, they're preaching for lunch. And so then it really is counterproductive for what they're trying to do in the community. So our big idea, right, to get down to it was to take these things that we have, the accounting systems, the grant writers, the Research Institute, the capacity to report, and to begin to empower these Latino pastors as points of service delivery points throughout the state of North Carolina, and at the same time trying to help them maximize their assets with their facilities so that where we can help create some sustainability for them as well, cross-train them as community health workers, or a term we use, social navigation, because they're doing it all day anyway. And so we're hoping, not just hoping, we're going to get them paid. And so over the last few years, we have been very fortunate that we were written directly into the state budget for North Carolina. It was an appropriation. And so we are just so excited to be able to plunder Egypt to do the work of the Lord and train these pastors to do this good work. And it's a lot of fun. Is that going to have some?
It's just not going to work.
It's not going to work.
Just keep talking.
So, but in so our health center, we have integrated health, we have the medical, we have behavioral health, we have psychiatry, we have nutrition, we have lifestyle, and then we also have a program called Arriba, which is all things about upward mobility. We teach English as a second language, we do resume building, we do job placement, we help with legal services, we have a big food pantry where we distribute about a week's worth of groceries to about 100 families a day, 5 days a week. Our total capacity in the Charlotte area, we serve around 50,000 unique individuals a year. And then we've started this pastors network of about 700 pastors in North Carolina. So now we're training them. We've got a couple pilot programs that we've established with a collaborative impact model that we are getting the local resources together with local universities, local government, and trying to convene all those resources so that we can get these services to these amazing people. And I got this thing right here, El futuro es latino. Anybody here speak Spanish? Oh, yeah, look at you guys. All right. So when I say that El futuro es latino, if you look at the demographics of this country, right, this isn't some kind of war campaign. This is a destination. This is a demographic destination. The most common age of white America, not the average, the most common age of beautiful white people like me is 58. The most common age of Hispanic USA is 11. The recent census that came out, 50% of the growth in the U.S. over the last 10 years have been Latino. The average household is 1.7 kids per family. The average Latino family has 4.3 kids. So if you look at what's happened, and we count the 2 in the car, we miss the 4 in the trunk because a lot of Latinos don't want to be counted because of our whole debacle of immigration. So we know that is severely undercounted. And so what we see where we live is Gringolandia. We live in North Carolina. Systems aren't prepared for this huge influx that's already come. And so we believe that the pastor, together with these types of entities we're building out in these communities, can help elevate the whole community by reducing cost of health care to the whole community. The behavioral health, so many of them have been through trauma, so the behavioral health is extremely important. We have a course of behavioral health first aid that we've taught all these pastors. And so anyway, working together as a community in this very beautiful community that is emerging, we think we're going to see some major things happen. And it's an honor to be here with all you incredible people. One other innovation we did, we merged a deep South white church with the Hispanic church that we started, thinking all heaven would come down and all hell broke loose. And God did miracles, and he saved the place, and then the funding came. And one of the innovations was, for communion, we changed from wine to tequila. And the offerings went up. That's not true. I'm teasing. But anyway, I don't know if you have some more questions or things like that.
Tell them about your good news about the Bezos grant.
Oh, so this is another crazy thing, too. So we just got word, like 3 days ago. How many of you guys write grants or your organizations go for money? And so every once in a while, like you say, okay, we're going to shoot for the stars. And there was this, what's the Bezos wife's name? Mackenzie Scott, right? She sent out this thing. Say, hey, why not? We'll shoot for it. We got a letter like 2 weeks ago that, we had asked for $1 million, and they're not giving us $1 million. but they gave us $2 million, and it hit our account like today. So I'm going to invite you guys all to dinner. Let's go party. But I do have to say this, as faith, we were faith missionaries, sold everything we had, stepped out with nothing, have lived. My wife and I have married 34 years. We moved 35 times in the first 15 years of marriage because I wouldn't sign a contract. We lived in homes. We've been as poor as you can imagine. And but we've seen God do this miraculous. He's done the miraculous over and over and over again. And one of my favorite verses is found in Thessalonians 5, verse 24, where it says, God who calls you is faithful, and he will do it. So no matter where you are in this journey, right? I think a lot of times we look ahead and we're like, man, I would love to do this. I have this compelling desire and calling to do this, but I just don't know how it's going to be funded. Can I tell you something? Your Father in heaven owns it all, and if he's calling, he will provide. And so many times faith and stupidity look exactly alike until God shows up, right? And so I could stay and tell you story after story after story of how God took us from imminent demise, where there was no way out, and then in one phone call or one time, he swapped it around. And so, we're in this stage now where we're trying to learn. We knew well how to live in need. Like Paul said, I've learned whatever state I am to be content. Man, we're good at living in need. I'll buy dead men's clothes off eBay, look nice, smile, but now we've stepped into plenty. And so now the challenge is to know how to live in plenty and not lose our faith, right? And so what I tell my team all the time, God is not afraid of zeros. And so if he can supply 100, he can supply 100 million. We will always continue to go boldly into the next thing, regardless of what our P&L says. We listen to our Father, not our P&L. And so I just encourage you in what you're doing. You are doing the work of God. You are the hands and feet of God. And sometimes it gets discouraging. Sometimes it gets heavy. Sometimes you think nobody sees. But I promise you that when we get to heaven and God begins to divide the sheep and the goats, y'all are going to be on the right side. So God bless you. I'd love to be able to talk to you later during these next few days. And thank you.
Thank you, Rusty.